about a new device that we're developing at UC Berkeley and UCSF. It's called SmartGerm, and it's intended to reduce the incidence of pressure ulcers in hospital patients. So just a little background. I'm a graduate student in the Master of Translational Medicine program. It's a joint program 1 year between UC Berkeley and UCSF, and it's focused on business, clinical R&D, and bioengineering. So the main focus of the program is a central year-long capstone project, and we're in groups of 2 to 4. So the presentation I'm about to give is representing the work of all of these people, Zoe, Michael, me, and Julie. And you can see that we have a pretty diverse background. And it's centered around bringing a single device or product from pretty much bench to bedside. So developing a new idea and finding a way to go and put that in the clinic. So this presentation is going to be focusing a little bit on the clinical need and why we want to go make this device, but a lot of it's going to be focused on kind of the engineering. So hopefully it should be interesting to you guys because it's going to be something new. Because what we're going to be showing is how we engineers build the devices that you doctors are going to be putting in the clinic. In return though, we're also going to be running a few clinical trials. First, a retrospective study to go and find the risk algorithm. We're going to go into that. And also another study to go and see the efficacy of our device. So in designing those studies, since many of us have an engineering background, we're a little bit hesitant about our studies. So it would be great if you guys could give me any feedback or any advice in terms of running either of these studies. So on to just a quick thing. This is our UCSF team. Dr. Henry Lee is the project leader, and here's the rest of the people. Professor Shubaroy is in charge of the engineering side of things for our advice team. So here's a little background on pressure ulcers. Decubitus ulcers are also known as pressure ulcers, and they are lesions that are caused by unrelieved pressure, and it damages the underlying skin. There's many factors that can contribute to this. So there's pressure, there's moisture, there's shear, there's friction, and heat. It occurs because of the capillaries in the area. When they're under pressure, they get cut off, which cuts off circulation and eventually causes the breakdown of tissue. You see that there's 4 stages. Stage 1 is just the surface tissue is damaged. Stage 2 comes down to the dermis. Stage 3 has further, even comes down to the fat layer. And stage 4 is the most severe. That's where the damage comes all the way down to the bone layer. It generally occurs in the back of the head, the shoulders, the lower back, and the heel. And this is mainly because that's where the patient is in contact with the bed, and occurs mostly in patients that are immobile or not moving for a long period of time. I want you to remember this graph where the pressure ulcers are occurring, because it's going to be important in a second. Just going over a little bit of the background of the market need. Pressure ulcers occur mostly in hospitals, hospices, and homes. In terms of some statistics, 80% is the increase in how many pressure ulcers have occurred over the last 20 years. The increase is related to the fact that we have an aging population, and as you have an aging population, then more people are going to be in the hospital for various conditions that may leave them better. 2.5 million is how many Americans are affected with a pressure ulcer each year. And 60% is a somewhat shocking number, but this is how many, this is the percentage of elderly patients that once they are discharged from the hospital after being diagnosed with a pressure ulcer, actually die within a year. So a pressure ulcer does have a correlation with patient death within a year. In terms of the cost, it costs on average $43,000 per patient to go and treat the patient for a pressure ulcer. This totals to around $11 billion per year for the American healthcare system, and 2.5 times the amount it costs to go and cure or treat a pressure ulcer than it does to prevent. 0% is how much Medicare and Medicaid actually cover for pressure ulcers now. At this point, there's a law passed in 2007 that said that never events that ought never occur in a hospital, are no longer going to be covered by insurance, and now hospitals have to go and take the cost. So interestingly, before this happened, hospitals had no incentive to go and cover for pressure ulcers, or no incentive to even prevent them, because they could go and bill the patient for the initial condition as well as for the pressure ulcer treatment later. But now that hospitals no longer are going to be getting money for that, they're incentivized to go and prevent. But even more importantly, starting this year, hospitals are going to be fined and penalized for the incidence of pressure ulcers. So now there's a very, very big interest by the hospitals to go and have a way to go and prevent pressure ulcers, and that's why prevention is key. Right now, the main prevention techniques involve risk assessment, skincare, nutrition, repositioning, and support services. The risk assessment is mostly through the Braden scale or the Norton scale. These are just 2 scales that nurses use to go and determine whether or not a patient might develop a pressure ulcer. It has fairly good sensitivity and specificity, but its predictive ability is really poor. It's about 40%. In other words, if you flip a coin and decide to treat a patient whether or not it's heads, you get a better chance of predicting whether or not the patient's going to get a pressure ulcer than by using one of these scales. So even though the risk assessment is good, it's still important to go and have a device that perhaps can better predict whether or not a patient's going to be getting a pressure ulcer. So overall, these methods are subjective, time-consuming, and ineffective. There needs to be a better way to go and determine whether or not a patient's going to get a pressure ulcer and then treat that. Right now, there are several competitors that we have on the market. You can see that most of them are, the minimum is, this one is $24.75. They're all above $2,000. All of these are just basically pressure maps that they go and place on a bed, have the patient lie down on that, and determine where the pressure points are. So even though these have, they are called different things, if you go through their list, they don't say they have amazing predictive ability and everything. The basic technology just comes down to this. They want to go and develop a map of where the pressure on the patient is. Sometimes they go and put it in tablet form. And the most expensive one, they go and say they have an amazing alerting ability to go and tell nurses when a patient might get a pressure ulcer. But the technology is actually just a timer. Every 2 hours, it goes and warns the nurse and says, there might be a pressure ulcer, move the patient. And that's the extent of the technology. One thing I want to note is, this is kind of the main thing. They want to go and give a map of the pressure on the patient's body. But this map is the exact same thing that we already knew here. We knew that you see that the hot spots are on the back of the head, the shoulder, the lower back, and the heel. And that's what we already know by literature. So what we really need, instead of having a big full map of the entire patient, what we would need is focused and specialized pressure sensors at each of these locations that can give real-time data, that can go and give fine-tuned data that has high resolution. So the challenges of making this type of device is, one, we have to go and determine which patients are at most risk. So some patients, for example, who are our age, are not going to have a high risk of developing pressure ulcer. However, patients who are older, patients who might have diabetes, who might have other conditions that might affect their circulation, they might have a higher risk. So it'd be more important to go and treat those patients before. In addition, we also would like to go and predict the pressure ulcer formation beforehand. And if there's any cues in the pressure itself beforehand, so if you can see that there's a change in pressure and that corresponds to the formation of a pressure ulcer, that would be very good for predictability. So that brings me to the smart derm approach. Smart derm is the approach it's the product that we're trying to go and develop. It involves real-time monitoring of the patient, which is then sent to a tablet or an iPhone where you do data analysis. That data analysis will incorporate a risk assessment algorithm that we developed from using patient EMR data. So we're going to go through a lot of electronic records and find out if there are any correlations between different conditions and the development of pressure ulcers. So this is part of the retrospective study that I talked about before, and this is where we would like some advice from you guys. And then once we get all the data and we do the analysis, then it alerts the nurse to go and have a more smart algorithm to determine when to reposition the patient. So first I'm going to focus on the real-time monitoring and the engineering involved in that. Here is the early prototype. This was worked on before the MTM team came on. And you can see that they had a basic pressure pad, an electronic box, and that it displayed out a raw data of the pressure to an iOS app. The basic theory behind this is that you have a piezoelectric sensor, and you have an array of these sensors. And you go and get a measurement of how much electricity is going through there. And based on how much pressure is placed on the sensor, it changes the resistance of the piezoelectric sensor. That is sent to a microcontroller, which is then sent by Bluetooth to an iPhone. The advantages of this is that it's extremely low cost, it's disposable, it's unobtrusive, and it moves with the patient. You can only place it in a high-risk area, so we don't have to worry about getting the entire patient map, and you get higher resolution in the areas of interest. The problems, though, is that it's very time-intensive to make. So you can see it's a fabric sensor, and one of the engineers actually had to go and hand sew that together, which obviously was kind of annoying. And then it's not easily cleaned, and it's opaque. So it's very difficult to go and see if a pressure ulcer is actually occurring under the fabric. So that's when they called them the MTM team. And they asked us to go and they tasked us with developing a new type of pressure sensor that will allow us to better treat the patients. So this pressure sensor you see here is what I'm going to be going into right now. The basic technology behind this is PDMS technology. PDMS is polydimethyl siloxane. It's a commonly used polymer that is used throughout in nanofabrication and a lot of bioengineering protocols. The benefits of using PDMS is that it's soft and flexible, so it's easily movable upon the patient. It's transparent, so you won't have any problems of not seeing pressure ulcers forming. It's easy to sterilize and manufacture, so either you can go sterilize every time, or you can even make it disposable. It's very inexpensive, also adding to the disposability of it. It's already used in many other medical applications, so it's not going to be difficult to convince the FDA of its safety. And the main technology, the theory behind it, is that if you add carbon fibers to PDMS, you get a variable conductivity based on the percentage of carbon fiber. So this is called the percolation threshold. And the basic theory in that is that carbon fibers are highly, highly conductive. If you have a lot of carbon fibers next together, then you can actually get a very conductive material. However, if you have a lot of carbon fibers that are spaced far apart, then it's not going to be as conductive. If you can get a range where the carbon fibers are spaced apart at a certain interval, such that when you go and press the material, the carbon fibers come together and increase the conductance. And if you don't press the material, it comes apart and decrease the conductance. Then you'll have basically a pressure sensor. So there's the percolation threshold, which is the ideal concentration of carbon fibers that will allow for us to make a pressure sensor just using PDMS and carbon fiber. So we found that percentage is around 0.1% of carbon nanofibers by weight compared to PDMS. So now that we have the pressure sensor, we want to go and send that information by Bluetooth to an iPhone. So I'm going to go a little bit into the Bluetooth technology that we're using. Here's a picture of the pressure sensor that we built. This is going to be an early proof of concept. Eventually we want to go and have an entire array of pressure sensors, but right now it's just going to be a single pressure sensor, a single input, single output, just to go and see if the PDMS carbon nanofiber technology works. So we took this pressure sensor and put it into a basic circuit, connected to a Bluetooth chip. This chip is called the BLE112. It's developed by Blue Giga. And the great thing is that there's a breakout board that's connected to it that comes with it. And we can do all the programming that we need on that. We can get all the, do all the input and output. And they have tons of pins, so we can go and do any of the electronics. So it's a really, really convenient platform for us to work on. So with this basic setup, we go and have the pressure sensor and connect it by a circuit, and we have voltage that is supplied to that. So if you go and press on the pressure sensor, then when the, since the carbon fibers come together, it increases the conductance, which allows electricity to go faster, which goes and, or not faster, it increases the current. So we were able to go and transfer that to an iPhone and get a basic readout of that. I want to go a little bit into the economics, because remember I was talking about how the current products are all above $2,000. So if you have a basic 2-inch by 2-inch carbon nanofiber PDMS sensor, the PDMS is only going to cost about $2. It's really cheap, really expensive. It's really used throughout all of biotechnology, so it's very easy to get. The carbon nanofiber is actually extremely cheap. We have a big bag, about 1 pound of it, and we use 0.01 grams of it each time we make a sensor. So we're going to keep that bag for pretty much the entire life of SmartRoom. So it effectively doesn't cost anything. It's 0.01 grams and $0.04 per gram. So it's extremely cheap. And lastly, the Bluetooth is going to be the most expensive, but even then it's going to be less than $20. The actual chip is around $4 to $5, so it's going to be cheaper. Including the breakout board, it comes out to $20. So overall, just back of the envelope calculation, you can see that SmartTerm only costs about $20, 2 orders of magnitude less than the next leading competitor. So we're really excited about the technology. It seems to be really effective and really cost effective. So now I want to go a little bit into what we're going to be doing with the data once we get that data. So first, we're going to do some data analysis on the data. It's not going to be just the raw pressure data. If you have raw pressure data, you can see that there's spikes here and then there's not. There's points of low pressure there. We can go and convert these discrete points into a continuous map using various filters, and these are just the image processing algorithms that we can apply for pressure mapping. So this, instead of having discrete points, you get to go and smooth it out and find a more realistic contour map of a patient's pressure. You can also maximize the change, the difference here, if you're interested in finding where the areas of, if you're interested in highlighting the hotspots. In addition, you could also do something called edge finding, where based on the difference between the pressure, if there's an area where there's a very little pressure and then very high pressure, that might be of interest clinically, because that could be an area of high risk. So there's various algorithms you can do to go and focus on that data. However, the most important part of our algorithm, or of our iPhone app, is going to be the pressure risk index. And this is going to involve all the patient EMR data and get all the comorbidity factors to go and rate a patient based on what their likelihood of developing a pressure ulcer is. So to do that, we need to go and do the data extraction. So these are the 4 basic studies that we're planning on doing. Right now, we're focusing on the retrospective database study and find out what the most important risk factors are. To do this, we are trying to go and find the overlap between patient risk factors and hospital-acquired pressure ulcers. We're right now looking at all the UC medical centers and using the ICD-9 diagnosis to extract the data from the IDR. the tools that we're using are Apex, My Research, UC-Rex, and of course CTSI. We're going to be using the free stats consultation for that. And right now, our team has been trained for Apex and My Research. We still need to interface with the other two. But again, we really need help from you guys. If there's any advice that you have in terms of data extraction, we'd really appreciate that. Eventually, we want to go and do a prospective cohort study to find whether or not pressure mapping identifies patient at risk. So the basic outline of that is we're going to go into surgery, into intensive care units, and rehab facilities. There, we're going to go and any patient who is going to either go under surgery for longer than 4 hours, or patients who are in the ICU or rehab clinic for greater than 48 hours, we're going to go and place the pressure sensor there and run the SmartDerm algorithm and see what our device determines, see if it's able to go and predict anything. Then later on, we're going to remove the device and then track the patient, and if the patient later on develops a pressure ulcer, then we can see if our device is able to predict that or not, if there's anything in our device that spiked before the patient got a pressure ulcer. So trying to see if there's any correlation. This is just going to be a very early proof of concept stage type of trial. Eventually, we want to go and do the placebo-controlled randomized double-blind study. Here's a quick timeline of what we're planning on doing. This is mostly for our update presentation, but we're working on the sensor and the iterative prototyping right now. We're going to be doing the clinical study starting in winter and then continuing that into spring. And then in the spring and then into fall of next year, we're going to be focusing on the IP and business. So that concludes my presentation. I'm happy to answer any questions you guys have.
I think it's I think it's actually a really awesome idea. Why did you guys choose to go with something like a Bluetooth instead of like using just like a local Wi-Fi?
The main thing with Bluetooth is that there's many medical devices that already do use Bluetooth. So there's the Bluetooth, the special interest group that goes and lists all these medical devices, and it just kind of helps with the marketing. And also because developing the applications for the Bluetooth is very easy. If we do buy Wi-Fi, then we have to go and deal with hospital network security, and just the database is going to be very difficult to work with. By Bluetooth, we just go straight from the device to an iPhone, and if we can do all the work on an iPhone, then that'll be really convenient.
Is like range ever like an issue with that though? Like, does the nurse have to be inside the patient's room to like and see what the pressure map is, or can they just be basically sitting at like at the nurse station?
That actually is a good point. We didn't consider that because we do want the nurse to be alerted. But then you're right, if we're going to be using Bluetooth, then it does have to be in the room. So one thing that we are considering to do for that is having a device that stays in the room, that is just a dedicated device that is connected to the SmartDerm device. And then that we go and set up protocols in the iPhone application that allows us to go and send out alerts. But yeah, that's definitely a good one to go on consider that. Any other questions?
I'm curious if some of those other competing products have done similar studies where they've looked at sort of pressure maps over time and demonstrated that they've been predictive. Because I'm wondering whether it's sort of a point-in-time pressure measurement that would make it the highest risk of getting a pressure ulcer, or my hypothesis would be that it's probably the duration of time that you're at a specific pressure.
Yeah.
So I guess what I'm trying to ask is, what will this bring to the table that some of those other products haven't?
That's definitely a good question, and those are the two things we're trying to determine in our study. Interestingly enough, most of these competitors, they are not in the medical device field. They make medical devices pretty much what they've done is they've developed a pressure sensor, and they're trying to go and find a way to go and use it. So they have actually been using it for like foot mapping to help athletes determine like what the best contour for their shoes are. So it's more of a technology looking for a problem to solve rather than going grounds up from the needs finding. So with us, since we're starting from the needs finding, I think that's where we're interested in finding this data. We're doing the literature search right now to go and see if anyone else has done anything to help us identify the risk analysis algorithm. But there hasn't been much published to talk about what factors might lead to a pressure ulcer, or what if they've tracked the pressure and seen that lead to a pressure ulcer.
I guess just playing devil's advocate, what changes do you see coming from this? Because already most hospitals, they have a protocol in place. You need to turn the patient every X hours, and I bet you can say that it doesn't always happen at that schedule.
Yeah.
But is your envisioning that some patients you might be able to turn less frequently if you find that sensors are not indicating that the pressure is that high?
So actually, based on what you're saying for how it might be the duration,
yeah.
What we're hoping to find is just a data set that if we go and track that data over a certain period of time, that we go and correlate that if the patient's pressure looks like like this, then we see in many studies that that leads to a pressure ulcer. So right now, even with a 2-hour rotating of the patients, there still is a very high instance of pressure ulcers and still does cost a lot to the system. So even at their best, the nurses aren't able to go and do it with the current system. The other issue is that you can just go and increase the number of nurses there, and that's what hospitals are doing. They're just kind of throwing nurses at the problem. But then the cost associated with that also increases exponentially if you have more manpower. So if there's a device that goes and decreases the amount of work that nurses have to do, we think that hospitals will be interested in that. We're trying to do that.
It's pretty good. I just don't know how the way it talks to data. You create your own abstraction.
Okay, because, so when I showed the team, we had 4 people. So the clinician on our team is the one who's focusing on the clinical studies. And she's the one who's actually working, she's spending this week trying to go and learn how RedCap works. So can I actually get your email? I can get this right now.
I don't have that much to offer, but I'll tell you.
Okay, because like she's
It's a
still.
pretty straightforward tool. You just make your abstraction thing, and then like gives you a giant Excel spreadsheet. And it just means there's less room for error.
Okay, that'd be great. Because honestly, like she sent me here and then said, ask them if there's anything at all because it's relevant. So that'd be great. Thank you.
For your interest, there's also RedCap training classes that are, well, I think, only like an hour long or something. So, yeah, so if you took the time to train EPEX and the other ones, I think this one is probably worthwhile.
Okay, sounds good.
Yeah.
Just a question. How big is the smart meter?
How big is the device?
Yeah, because like I noticed in your calculations that like you said that's one device, but is that only for like one part? Because then technically you would have to put it on 4 different places.
Yeah, so it's going to be one device in each location, and we're going to be shaping the device according to the location because we want to make sure that the device has a certain contour so that it doesn't cause a pressure ulcer. So we're going to be working on that. We haven't determined the final size and shape of the device, but we estimate that it's going to be around that same size. And again, you can see how cheap the DMS is, so even if it's going to be several more devices, it's going to still be 2 orders of magnitude less than the competitor.
Sachin, coming back to Moose's comment about the smartphone and Bluetooth, so are you then going to have to figure in the smartphone into the cost?
Into the cost of the device. So we're not expecting to be selling a smartphone with the smartphone device. And at least in terms of what the doctors who are on our team, they said that it is a reasonable expectation to think that these devices will be available. And at least for the initial testing, we're going to have that device available. But I'm definitely going to go back to our engineering team and then talk about the consideration of how we're going to, for the final product, how it's going to be interfaced with the hospital environment. And one thing we could do is, I think some of the hospital monitors in certain hospitals are also connected with Bluetooth. So if you just go and connect directly to that, that would be the most convenient, so they don't have to worry about it or any other device.
Great. And then coming back to the clinical studies part, have you done, what stage are you in terms of that, in terms of power calculations and all that, and conceptualizing how you're going to categorize the exposure? Like is it continuous? Is it going to be discrete? You're going to say like red versus everything that's not red?
We haven't determined that stage yet. Right now we're just trying to go and focus on the prototyping. And then for the study, we're just trying to get as much data as possible. And because right now we don't know what factors might contribute to it. Again, I guess it comes back to what Musa was talking about, is not knowing which factors might directly contribute. So we're just getting the data now, and then once we start testing in the clinic with our device, then we'll hopefully be able to narrow it down.
But I would I would suggest that you think the other way around, in other words, try to figure out what question and what outcomes you have. So that because you're going to spend a lot of time capturing data, you want to at least know if you want to, how many hospitals you need or what N you need, instead of just capturing the data and then trying to figure out if you have enough power.
Okay, that makes sense.
Because like Julie was saying, you're putting a lot of work into capturing these outcomes, but if the goal is so far away that you're never going to get there,
we might have to go change the approach again. Yeah, that definitely is a consideration to consider.
Of course, it could be proof of concept or hypothesis generating, in which case you can just capture the data and then try to run statistics on it, whatever you have.
But then we do eventually want to show improved efficacy. So I think, because we are doing proof of concept right now, but since we eventually want to prove efficacy, we might as well go and get that data now.
You have the biostats people from CPSI, you should have at least figure out what outcome you want, primary outcome, and how many abstractions